What's going on, everyone? Welcome back to the podcast. We have another awesome guest with us today. We have Jay Bowen, who is a board-certified physician specializing in physical medicine and rehabilitation physiatry, which is actually the residency that I'm in now. He's also a sports and pain medicine physician. He's certified in the use of prolozone therapy for subacute and the treatment of chronic pain. Dr. Bowen currently serves as the medical director of the New Jersey Regenerative Institute in Parsippany, New Jersey, and has been working with patients for more than 25 years. Dr. Bowen manages all aspects of neuromusculoskeletal pain and performs various interventional procedures, including orthobiologics, joint, epidural, facet, and sacroiliac joint treatments. He also specializes in delivering medical ozone through systemic high-dose ozone / UBI insufflation and local prolozone injection. So Dr. Bowen, welcome to the podcast.
Thanks for having me.
Appreciate you coming on. And I think that you're definitely practicing in a space I'm very interested in. So I think for our listeners, it would be awesome if you can kind of just, I guess, talk a little bit more for those of you who don't even know what physiatry is, what your path was to kind of getting into this specialty. And also specifically, it seems like you do sports, pain, and regenerative medicine.
Yeah, so as you said, I've been doing this for quite a while. So I started out wanting to be the team physician for the Oakland Raiders. But I really didn't want to do surgery. And so I started my journey off. And then as a second year in med school, there was a person that came in as a physiatrist and told us about this field. And I said, wow, that's exactly what I want to do. I never knew it existed. So that sort of started the next steps. And I think as an osteopathic physician, that pretty much dovetails in with the good musculoskeletal anatomy and the functional anatomy, and that sort of bias and perspective. It's a little bit different than allopathic medicine. So I did an internship in Buffalo that sort of rotated around different aspects of medicine. Then I did my residency at BU, and then I did a fellowship. I came down to Jersey, and Joe Feinberg was the head at that time, who went to HSS. And then Jerry Malaga, who unfortunately a good friend and everything, he passed away recently, and was just a big presence in the field of physiatry and regenerative medicine. So I just was blessed to work with him and be a mentor and then friend and then colleague. So if you're on the West Coast, it's physiatrist, right? And if you're on the East Coast, it's physiatrist. So I tell patients they have no clue. I go, yeah, I'm like a psychiatrist and a podiatrist. I treat everything from the head to the toe. So there's some unique to that. There's a lot of reality to it. And then we started off early on, doing things like diagnostic musculoskeletal ultrasound before I was even in. With Jerry, helped out. We did some academy training to the musculoskeletal medicine. And then fast forward a little more, and I started being sort of the contrarian to Jerry, and we started looking at other aspects of how traditional medicine is done with steroids and how that might not be the best. And then we started getting into prolotherapy, right? So proliferative therapy, a term coined in the 50s, and multiple things have been used to stimulate healing. Like to think about like grandfather name, where now we have sexy stem cells, which is just another way to stimulate someone's healing. So really the old form of prolotherapy. And then in the 1800s, actually used ozone gas to stimulate healing. So just another modality you can use to stimulate healing. And then, started doing a pre-course of the Academy meeting for regenerative medicine, helping with books with Jerry, research that we have, trying to focus on doing regenerative medicine or orthobiologics for the disabled population, which unfortunately nobody's doing. And I find that somewhat disheartening that the physiatry residencies are not doing that when that's sort of their wheelhouse, that they could adopt that and focus that. So as we do our research, we're trying to, get those disabled populations, the lower socioeconomic income people, because right now it's really sort of self-funded research and it's self-selected bias. So we don't know if it's going to be better or worse in that population. That's sort of a general overview. Hopefully I gave everybody a little taste of what I do. So I do a little bit of everything.
Awesome. So what would you, and that's a great point you bring up about the disabled population and population that's at a lower socioeconomic status. I imagine because a lot of these treatments are not covered by insurance, how is the only way right now you're seeing a patient get these types of treatments, I guess, if somehow they come up with the money or they're doing one of your studies, like where do you see it as the future? Is there a way to get costs down for this, or kind of what are you seeing?
Yeah, I mean, that sort of dovetails into what we did in 2018. We started a company called Data Biologics. So Dr. Malang and myself and Chris Rogers in California, we all partnered because we said, you know what? People come in and go, oh, orthobiologics, which wasn't really a term at that time. Regenerative medicine is, bunk. It's stupid. It doesn't work. And we're like, no, it's not accurate. And then other people go, oh, it's the greatest thing since sliced bread cures everything. We're like, no, that's not accurate either. So we have a tool, and we have
Right.
to figure out who is the best person to apply what tool to. Because you have PRP, you have fat, you have bone marrow, you have a lot of tools, even in that subsection of orthobiologics. So with data biologics, the goal is to, so we've been collecting data since 1999, or when I was a fellow, or even before that. And we went from pen and paper to multiple different computer systems. And it was so labor intensive to put it in and then try to extract it. And, technology's advanced a lot. So we wanted to capitalize on that. And now everybody's got a little computer in their pocket called a, phone. And so we decided to try to make an app. And that moved on to something more sophisticated that we have as data biologics, where people are doing novel treatments, not just orthobiologics now, but any novel treatment that can be disruptive technology. Instead of just going, it works, you can actually follow your patients and look at outcomes that are validated and find out, well, who does it work for and how well does it work? And you can contrast that. Once you get enough data, and we just recently entered our 20,000th patient in the database. So once we get numbers and time, then we can potentially go to people who actually care about cost savings, right? So I always ask the residents, what if we assume that every business wants to make money and we throw that out the window? Like, what is the insurance company's business?
Making money.
That's what everybody says. But yeah, we already know that. But how do you make money? They
So they're
manage,
they're they're trying to be cost effective.
well,
So
so
I would
they
imagine.
manage risk, right?
Mm.
So if you have 100 gallbladder surgeries a year and you know how much that's going to cost, and somebody comes in and says, hey, I have this fancy new tool that I can do it under video game, lap pulleys. Someone goes, well, how do we know we're not going to pay cheaper in the short term, but then have all these complications and pay more
Right.
in the long term? And that's really where we're at, I think, with orthobiologics and whatnot, is that we need to prove, A, who gets better, and B, who actually needs it, right? So we found that, hip, ball, and joint sort of arthritis does least well for orthobiologics. Doesn't mean everybody doesn't respond, but if someone has significant restriction in motion, we generally, unfortunately, I refer them to a surgeon. I mean, like, hip replacements do very well. They respond a lot faster than knees, and we don't have great success with the orthobiologics. So, there are times you say, listen, my tool doesn't work for you. And once we know that, then we can go to an insurance company and they won't feel sort of, as we'll call it, scared or trepidation of going, oh, I'm going to actually end up paying more in the long term. So our thoughts is, once we have the data, we can go to, say, a self-indemnified plan.
Right.
So workers' comp, things like that, that actually look at, day to day, how much it costs. Because if you look at a big, whether it's Medicare or Aetna or Blue Cross Blue Shield, they almost don't really care that they save money, right? Provocative statement, right? Because why? They have no cap on premiums. And we all know in
Hmm.
experience, those premiums just go up by 80 to 100% a year. So unless we cap those premiums, they don't really have an incentive to control costs. And unfortunately,
Right.
the middleman there, the administrative, thing is the huge part of their expense. So, they're going to manage risk to control costs and then keep money in their pocket. And, that's how they make the money.
Yeah, no, that makes a lot of sense. Are there any things you said, like that's a good insight? Hip, like if someone's really restricted, you're not seeing as good results. Is there something that you had a suspicion that you would see good results with, that you are with that data that you've been collecting, or anything that you feel like is coming out that you're excited about specifically?
Yeah. I mean, the thing is that we generally do quite well with regenerative treatments. Again, it's an art. And so, when people go, it doesn't work, you got to go from the beginning. What is the patient? Where are they at? What have they tried? How are their biomechanics? And I think that's the biggest thing that's missed. And, the physiatry advantage is we're really looking at functional anatomy. I'm really excited about fascia, and that's where I think ozone has an advantage in some of it, because it's a gas, flows differently in tissues, and we can see under ultrasound. And so the fascia thing is a big deal. We think about Newtonian physics, and yet people are saying that, well, that's not really accurate, right? We got to think about quantum mechanics. Same kind of thing. We think about, residency, they teach you about class 1, 2, 3 levers in Newtonian physics. But with the fascia, it can sort of transmit the information faster than nerves. And the fascial tightening and the way we actually move is through the fascia and the muscles. And it's not just sort of standard biomechanics, or I should say mechanics. It's more biologic influence. So I think the biotensegrity model, which I introduced to a lot of the residents, is a really key and interesting kind of concept. And it's really, we have compression and tension elements that all work in concert. So that's what's really exciting. I think these things can have some advantage. And it's really not, let's look at that tiny little rotator cuff tear, and everything on imaging is what we got to treat.
Right.
Imaging most of the time in orthobiologics, well, orthopedics, doesn't really correlate. Surgeons hate to hear that. They want to see something so they can image it and then surgerize it and then fix it. The problem is a lot of people don't do well after these surgeries. And I think a lot of it has to do with that they're just treating a picture, not a patient. So I just tell everybody, listen, I'm treating patients, not pictures, and try to minimize their focus on their MRI they come in with. Right? How many times have we seen MRI? I don't know what your experience in residency, but they have a big fat disc herniation to the right side and they have no pain.
Mm-hmm.
Or they have
Yeah.
a big fat disc herniation to the right side and they have left leg pain.
Or everyone's got a meniscus tear. That doesn't
Yeah.
mean
And we know right now there's
it's
starting to
going to
be
be
some
associated with
changes
pain.
in the literature where people are starting to reduce the number of degenerative meniscal tear surgeries. But there's still way too many done. The most common outpatient surgical procedure, 800,000 done a year in the United States, are meniscectomies. And what does that do? It reduces some of that meniscus to increase the load on the cartilage, so it degenerates faster, and you need an earlier knee replacement. Right? Fastest growing population for a knee replacement is 45 to 55 years old. That's insane. When I train, you wouldn't touch anybody under 65, maybe 60, but I used to say that, and now I'm in that category. I'm like, wow, I could never think about having my knee replaced. That's me. So
Right.
I think that people do really, really well with the knees, and we have pretty good success with all the tendons. So, and then we're also starting to incorporate other unique things like shockwave, whether it's a primary treatment or as an adjunct. So if you have someone who's got tennis elbow, you could potentially do injection to the, tendon at the elbow. But I saw when I did ozone, sometimes the gas would flow down to their, fingers. So I started thinking, wow, that biotensegrity model, that fascia in the forearm, may be something why people are resistant. So we'll do shockwave in the forearm, and then we'll do PRP at the elbow, or sort of combine a protocol, as well as thinking about someone's underlying sort of what protoplasm, right? Are they a healthy person? Do they eat well? Do they have really crappy lipids that they take in, like fast food, trans fat kind of thing, or good olive oil? Do they meditate? I mean, we go through everything from clean air, clean food, clean water, meditation, spirituality, stress management, exercise, biomechanics. I think that's where we forget about orthobiologics. We get all enamored by the sexy stem cell, and we forget about treating the patient and all these different parameters from the acquisition to the deployment to the post-procedure exercise. And when that's not done in concert, that's why people have a lot of failures.
Yeah, no, that makes a lot of sense. I would say post-procedure exercise and therapy also very important. Do you do that within your practice, or do you refer out for?
So we don't really do it
PT?
because we pull from a very large area. And so for people to come and drive to us,
Right,
be
that makes
inconvenient.
sense.
But we do have some relationships with some trainers, and they do some very interesting things called functional movement screens, which is really looking at movement patterns. So, you can isolate out the bicep and test it, but that's not how we work in life. So if you look at this whole movement pattern, how you really work, you'll just start to figure out things that are sort of wrong in that chain, and then you can address the whole thing. The thing that I still wrap my head around that I find still is that if you don't have good ankle motion, it can actually affect your opposite side shoulder, which just blows my mind still. So
you haven't figured out a mechanism. You're just seeing that in the results of those function tests.
yeah, and it's amazing. You start fixing ankles and toes and other things. It's like that, and hips, and it goes even beyond the biotensegrity and the osteopathic manipulative stuff and the fascia. It's all in concert. So as you load that ankle, you change your hip, you rotate your thorax, you open up your shoulder, and it's all connected. We gotta not forget about that. And if we get too focused on one area, our successes may not be as good.
Very interesting. So like I'm in PM&R residency right now in the city. I think most residency programs are not going to get as much exposure to regenerative medicine as a whole specialty. We'll get some PRP here and there, but I'd say probably that's pretty common for most PM&R residencies. How did you get that specialized training out? What did you get some of that training in regenerative medicine while a PM&R resident, or you had to kind of seek it out?
Yeah, so
And what would you recommend to residents?
So
Yeah.
I look a little younger, but I've been around for a while, so I don't really want to be, too arrogant kind of thing, but we sort of did a lot of this stuff on our own, right? I started out looking at how could you stimulate healing, because I had a bias towards steroids, in my med school, because I would look at it and say, well, if you have something inflammatory, steroids sound okay. But you look at Nerschel's work way back 40 plus years ago, and he said with the lateral epicondylosis or tennis elbow, which people still don't call it tendinosis, and he put out that term, is that after 11, 14 days, there are no inflammatory cells.
Right.
Why are we putting a steroid in that area? So I asked, so we talk about inflammation, and it was a pet peeve of mine because inflammation is not necessarily bad. But if you cut yourself, God gave us the gift of inflammation to heal. However, on the other extreme, if you have rheumatoid disease, right, you're inflamed, you're actually eating up the cartilage in your joints. So we have to think about sort of where that patient is on the spectrum. And my bias in my population is really degenerative osteoarthritis, non-rheumatologic patients. And so with that, I'm like, why are we doing steroids? So I said, what's irritating to stimulate healing, but not caustic to cause damage? So I actually started out drawing whole blood. The Japanese did quite a bit of that, injecting whole blood. But that was a mess. You have HIV and other issues. So then I found out about prolotherapy. I trained in that. I went to Honduras and trained. Then I started advancing. Then I found ozone. I went to Germany. So they layer on. And then PRP sort of came out. And there was the stuff from Mishra with lateral epicondylosis. And then we said, well, tendons. Well, then, we forget not every tendon is the same, right? We did a review with Dr. Malanga and a bunch of physiatrists around the country. And we found out that, the Achilles actually does the best and the patella tendon sort of does the worst, even though, it was, I think, 86% improvement for the patella and like 94% for the Achilles. So they're both
and that's with PRP or what?
What's that?
What was it? Did the best with what? PRP?
Yeah, with PRP. So, and then the question becomes, well, they're both lower limb weight bearing areas that are two joint muscles. Why are they different? So that made us think like, you know what? We can't just dump and say, oh, all tendons are the same. All joints are the same. We really have to be, more mindful and thoughtful and not just, short-sighted. And so we kept layering and layering. And then again, Dr. Malanga started, he wrote a book. I wrote a chapter in it. So we started doing a lot of this stuff in the beginning and, started then training people. It was a little mix into our fellowship. And now our fellowship's really migrated over to more of a regenerative medicine fellowship the last couple of years.
Got it. So can you talk about that a little bit for people who don't know? I kind of looked into it as well. It sounds like you guys have a regenerative med fellowship. Do you take just PM&R residents? Is it all specialties can apply?
Yeah.
So how long has that been going on for?
It was interesting. So Scott Nadler, who's well known in the physiatry world, unfortunately passed away of stomach cancer at age 40, started out the fellowship and got a mentor, Joe Feinberg. And that started around probably 1995 or so. And then we pretty much had a fellow after he moved on. Jerry Malanga became the chairman or director of the fellowship. And then when Jerry passed, I became that. So as we move forward, we did mostly spine and sports. A lot of sports, unlike a lot of programs didn't have that. And we were only a handful of physiatry fellowships that did that. Then the ECG meet came in and we said to our old fellows, like, does it matter to get approved? And they're like, yeah, we just want the training. So we decided not to go down that route. And then we started doing more spine. Then we moved off to more musculoskeletal. And then because of that dovetailing into regenerative medicine, and I would say probably the last 3-4 years, we've been more focused on that. So we've been lucky now to be funded by the Kessler Foundation, where we have a benefactor that provides the funding for the fellowship. And so we focus mostly on regenerative medicine. And I'm the visiting scientist for the foundation, which we focus on the research and I help direct them of what should be the regenerative medicine research that we fund and we sort of go after.
Got it. Very cool. So are you doing any spine as well? And what procedure? What's your thought process? Because for epidural, that's steroid. It sounds like you stay mostly away from steroid. So what's your stance on that?
Yeah, I mean, I think sort of neuroaxial steroids are, I still do. And again, I was sitting around one day and, just thinking about stuff. And I went, actually, I'm so negative against steroids, but, our body makes steroids. So I'm like, well, maybe there's an issue. So, if you look at it, and then Chris Centeno did a little work on this, the steroids are probably not bad, but literally, not hyperbole, we are probably administering about 1,000,000 times the dose we should be doing. So if you put 400 nanograms of steroid into a knee, you actually have chondroprotection. But nobody's doing that, right? So I actually did
Right.
math once. So I had to take 1 ml of a 40 milligram bottle, inject it 1/10 of a cc from a tuberculin syringe into a liter bag, then get a new syringe, take another 1/10 of a cc, but another liter, and just do that.
And
You're like,
draw.
wow, it became an issue. But so the devil's in the dose. And so steroids aren't, like everything. Nothing's all bad. It's just when we apply it ubiquitously without thought, that's probably where it becomes bad. So yeah, I'll do steroid epidurals covered by insurance, unfortunately. Although, I don't let that dictate how we actually practice. And then, to minimize, people say have hypertension or they have diabetes or they can't have the epidural steroid for some reason, we'll do epidural PRP, either transforaminal, interlaminar. If someone has facet problems, we do the medial branch diagnostic, make sure we establish the diagnosis. Then we can do, PRP in the actual joints. There's a guy, Inkelbacher, who published about 5 years ago from the UK about a whole protocol to inject the lumbar ligaments. Again, a big proponent I have of ligaments that really were stabilized joints, and then we see the resultant problem in the joint, and people start treating the joint. We forget about why did it happen, and so I treat a lot of ligaments outside the joint to stabilize the joint and then offload it, and then people have no problems. And so I do that commonly in the lumbar spine. There's about a 14 injection protocol. So we'll do that with PRP. For all these people who have sort of quote unquote discogenic pain, which again, very difficult to diagnose. And discograms have some, folly. So Jerry and I were always cautious about sticking needles in discs. That can be really bad.
Yeah.
We didn't have to do that a lot.
I also know it's contentious if discogenic pain is real or not as well.
Yeah, listen, my feeling is that discogenic pain is most likely from the end plates of the vertebral bodies. I've wanted to do for a long time so we all know about vertebroplasty and kyphoplasty, and there's a transfedicular approach to put the cement in there. There's a case report that the Endorep people did in Spain where they put PRGF in the vertebral bodies. And these people had great response. And I'm like, that minimizes the risk of damaging a disc and minimizes the likelihood of infection. And it's probably actually treating the problem, right? The intercept procedure is doing the same kind of thing, but they're doing actually RF of the end plate.
Right. That's what I was actually about to bring up. It seems like Interceptor, the BVNs are addressing that as well.
Yeah. So hopefully once I get some of our research projects done, I want to do that sort of PRGF in the vertebral bodies. And then if we can get about 10 people as a screen, then maybe get like Alturi, who's published on the bone marrow for low back, and he's really more bone marrow and disc. Say, hey, listen, let's get those other, multi-centers and see if everybody will do this procedure and see if we can figure out if it's as good, better, or indifferent compared to what we already know. So a lot we don't know.
Yeah. That seems like a big part of this space is also why there's a lot of pushback is the research just isn't there. But I guess if no one's doing the research, how can you find out?
Yeah, I mean, the issue is there's actually a lot of research. Again, we don't get to the level 3 sort of conclusive research, which is coming. Again, we're in the infancy of this whole new disruptive technology that nobody really wants to be successful except patients. And so, again, why we did data biologics. And, we're trying to raise money for that. So if you or your audience wants to go, we just put a crowdfunding thing out. So you go to wefunder.com/data biologics. And for, even $100, you can be part of it, own part of the company and support it, or just become a client and start putting your own patients in. So I see another reason we did this is we would go to conferences and people would say, oh, I do X, and everybody gets better. And we're like,
right,
it's impossible. Everybody doesn't get better. So I said, just put it, I'm not an academic person. I don't have time. They make a ton of excuses. So we made a simple, user-friendly and practical platform that can get you actionable and usable data out, it doesn't cost you a lot of money. So people got to put their money where their mouth is when they're doing novel treatments and show that what they're doing. And then they'll actually surprisingly find things that work better or not so much that they've diluted themselves, right? The old adage about, outcomes is you need research and time, and uncovers a lot of ills.
Right. No, that makes a lot of sense. What are you seeing in terms of like exosomes, or even, I know like stem cells really are heavily regulated in both the US in general and certain states more than others. I know we have like BMAC and other ways to kind of get stem cells, but do you feel like there's overregulation in this space, not enough regulation, or like where do you see the future of that going?
Yeah, it's funny. I'm putting together a whole thing for our academy meeting on the spine, and part of it is the regulations. Very deep and complicated, but so the overview is, I think FDA overreached a little bit, but I think there was some legitimacy to it. I wondered if you just leave it open. Unfortunately, so I have done lots of different things in medicine, but I see a lot of things from my peers, which sometimes upsets me. So I had a friend of mine who's a lawyer who goes, listen, he goes, there are 10% of people in the world that are bad. He goes, in medicine, hopefully less, and in law, definitely more. So you always have to remember that there are some bad apples. Even with, Dreamland with Sam Quinones, right? When you look at the opiate epidemic, you can have 1,000 physicians treating people right with opiates and never have an addict. And you can have one doctor who treats 1,000 patients and makes 1,000 addicts. That's the
Right.
problem in this space, right? If you have one person who does one wrong thing, even with, good intentions and the right technique, everybody suffers. So, this new thing comes in, it's disruptive technology. The FDA says, oh, we should regulate because it's, a drug. They don't really have a pathway to do it the right way. So they start trying to squeeze it into something it wasn't meant for with pharmaceuticals. And then they start, saying everything's a drug. Well, how is your body a drug? So there's been a few legal cases that said, it is. Therefore, if it's a drug, we can regulate it. And a recent one that was actually done in California, or at least on the West Coast, that said, the judge came out, opposite and said, no, your body, your cells are not drugs. So if they're not drugs, FDA has no regulatory, purview. And then people go, oh my God, there's no control. Well, as you alluded to with the states, there are some different states like Texas, but every state has a state board of medical examiners that looks at the practice of medicine. So there's still regulation out there. And you still got to do the right thing, right? If you're starting to do crazy things like, aseptic technique, you just throw out the window and you spin up dirty stuff and inject it and get infections. Yeah, that's bad news. So
Yeah.
I think that, again, we as physicians need to come together and do something we historically don't, and that's self-regulate. And no one wants to tell the doctor you shouldn't do something. And so if you don't want to tell them that, then just educate them on how to do it, not how not to do it. So, and then they have these arbitrary definitions like, what is a drug? Is bone marrow okay? I guess so. Then they have these HCTP kind of definitions where we don't even care about PRP, but bone marrow's in there and fat's in there. And then they have different definitions of homologous. Well, the breast is a tissue that makes milk for kids or babies, so it's not fat organ. Well, and then the plastic surgeons get all upset and like, we've been taking fat transfers for decades before you made a comment, Mr. FDA. And why are you now telling us all of a sudden we can't? So they get that changed to like, there's a homologous use that's structural as well as functional. And again, the FDA, for whatever reason, comes out and says, well, fat is not, bioactive, but fat's super metabolic, right? So, there are administrative things that we have and regulatory things we have to talk about with our patients that I always say don't always line up with the scientific evidence. So we have to balance those. Now, the one thing that's pretty cool though is that, Arnie Kaplan, who passed away recently, the guy who named stem cells, was sort of instrumental in the 21st Century Cures Act. And then Trump signed in, I think, 2018, the Right to Try Act. So these things now are allowing sort of more use of these. So if you have someone end stage, we'll call it NEOA for an example, has tried everything, doesn't want a knee replacement, or can't from cardiovascular risk and they might die during the surgery, they could fall under the Right to Try Act and they could get true stem cells in the United States, which most people don't understand. And so people providers a lot of times misrepresent things, whether out of ignorance or sheer marketing and trying to make money. And they're giving stem cells that aren't stem cells. They're someone else's. And to minimize risk of infection, they irradiate them. And even if there were stem cells, they just kill them. And so then you have to be careful about going out of the country because you don't know what you're getting. And we can do most of that
Right.
stuff safe and in the country now. So we work with personalized stem cells in California, and they'll bank people's fat. They'll do culture expanded fat stem cells, and they'll leave them there. And then if someone goes through the right to try and can get released, then we can use them for orthopedic related issues.
Got it. So you're taking all those stem cells from that, we're not talking like umbilical stem cells or anything like that.
Right. Right now, everything we do is we call autologous. So it comes from the patient, goes back to the patient. I think that the allogenic cells, which means it comes from someone else and goes to someone else, I think that's, going to take a while. And that's where the risk comes in of infection, which is really where FDA actually does have, standing. And then you also look at disease transmission and other potential risks that, probably are unwarranted in the fact that autologous cells can be sufficient. Everybody wants to put a little, vial on the shelf and say, hey, I have this stuff for you. But your own stem cells are probably good enough.
Got it. And so, okay, so that's very interesting. I didn't realize you couldn't even take from someone's own fat to create stem cells. What is that? So you're saying for some patients, you may recommend like they get it stored, and then if later on they are able to get it through right to try, they're then able to do it once they've exhausted all possible treatments.
Yeah, I mean, it's not always exhausting everything, but right now there's no regulatory compliant way to just take true stem cells, culture expand them in the United States, and then use them for an orthopedic related issue. But if you do it right, or the company really does it right, because that's the onus is on the company under right to try, and they qualify the patient, then they can actually take it and they can culture expand them and they can freeze them, freeze them. And then you have doses that are sitting there and you just pay a nominal fee a year to store them. And then say something happens down the road, you can just call up, do the paperwork and get a release really quickly. Sometimes we'll say we're going to do MFAT in the knee for a meniscal tear. We can take a little extra fat, ship it off, and then they'll have those sort of there. Because the biggest problem with this is, a lot of it is harvesting. So if you go through a fat harvest once, you might say, yeah, I don't really want to do that because that's my bigger recovery. Although a lot of patients are like, yeah, more fat, take it all off.
That's funny. What does that process look like when you're harvesting the fat? And so right now you're able to do it for if you're immediately using it, but is it the culture expansion that's the issue right now? That's like not technically legal?
Well, yeah. So it's something, there's 4 parameters, but one is called more than minimal manipulation. So if you take a cell out and you start, so specifically fat is a tissue, right? So you take the tissue out and you can do certain things like clean it, rinse it, resize it, but it's just a smaller piece of fat. If you start pulling the cells out, it's sort of like I talk to people, you have a sweater. And if you cut it up in small pieces, you still have cloth. But if you start pulling a thread out, you screw up the entire structure. So if you have fat and you pull out cells, now you've done more than minimal manipulation. And that's where it gets gray is this a drug or not? And then
Got it. Okay.
So if the question you asked is, so you come in, we're going to treat your knee. Well, this is one scenario. I take off extra fat. I send it out to California. They culture expand it. They store it. If you do great for 5-6 years with your knee and then all of a sudden it comes back or your other knee hurts, we can just call them up. They can have the paperwork done. If you qualify, release those cells, and then you can get it done your other knee or repeat the knee that we did, and you don't have to go through that fat aspiration. And as you know, it's like, how do we do it? So you could just walk in today and we could do a mini liposuction, just like a cosmetic liposuction, take off a small amount of fat, send it out to them, and they would culture expand it and then store it. And then if you need it in the future, they'd have it all ready for you.
Got it. And then the procedure, you let's say you're trying to treat procedure, like obviously you're not waiting, you're not doing right. So the reason you're able to do that now is because you're technically just injecting you're not like altering the tissue.
Yeah, everything we do in our office is regulatory compliant. It's less than minimum manipulation. So all this, fits within those regulatory guidelines, we may be able to do other stuff, but we don't really want to raise a yellow flag and have, FDA or anybody audit us. So we want to, be as compliant as possible. And if we need to refer someone to somewhere else in the country, we can do that. But, we have access to enough treatments to make most people better. Even when people are like, I want my stem cells, I'm like, yeah, you don't really necessarily need them. You have some degeneration of the tendon in your elbow. It's like you can kill a fly with a fly swatter or a magazine. You don't need a sledgehammer. So why do you want to go underneath that extra invasiveness, cost, all this kind of stuff? Well, stem cells are great. So sometimes we just have to do that talk, TLC, and let patients understand the PRP or the blood that you have can be just as effective and has more research on it. So, why do something more invasive?
Yeah, no, that makes sense. And then one thing we didn't, I don't know if we ended up getting to, thoughts on exosomes. I see that a lot now.
So, like what are exosomes? So I always quote Arnie Kaplan. It's sort of funny, his perspective, but, exosomes are stem cell poop. So, what are they're microRNA that's pinched off from a cell to communicate from cell to cell.
Right.
So he's like, listen, just stick the cell in there, forget about all these signals. So the cell can, the other thing is we forget, what is a stem cell? Well, there really isn't such a thing as a stem cell, right? So you have Kaplan who came out and said they're mesenchymal stem cells, MSC. And in 2010, till he passed away, he tried to change the name. He said, no, let's keep MSC, but they act like medicinal signaling cells. That's really what they do. So they sense the environment, they tell the body what they need. And so if you get injured and cut your finger, the stem cell protects your body from essentially attacking that diseased finger. And it senses the diseased area and tells the body what to get to repair it. And so if you look at, his mistake, he said, was he missed two things. One is the parasite was the precursor to the stem cell. And two is that, why does the cell do what it does? Because he's a PhD lab guy. And if he puts it on a certain media, it grows great. He puts it on a different media and it dies. So it's like I tell my patients, I give you grass seed and you live in Arizona and I live here and we plant it. Yours gets burnt out and mine grows because of the environment. And so when you talk about all these things like colony forming units, there's a lot of nuance in there that people don't understand. And so that in vitro or in the lab, the cells are going to look differently and they're going to turn into cartilage. They're going to turn into fat. They're going to turn into nerve with the right signaling, the right push. But in vivo, in the body, they almost never turn into the target tissue. They coordinate your body to heal that target tissue. So, exosomes in general are allogenic, so from someone else. So they're generally a drug, so they need to be regulated. Unfortunately, a lot of these companies have not done that. And even with the RMATs through the 21st Century Cures Act, they never reported or registered the FDA. So most of them have gone bye-bye now. They've had a lot of cease and desist letters. There is one company, though, that we used a little bit, and I think just need more data, and where you can do sort of autologous. So there's a way to process PRP and pull out your own, they say EV, so extracellular vesicles, which would be like an exosome, and see if you add that onto your PRP. Again, we just need to say, have one group do it 6 months and see, is it better for the cost than just doing PRP by itself?
Right. Yeah, I guess because the argument I've heard was that, with exosomes, you could pick which specific growth factors you would want. But I guess if you're PRP, because it's autologous, and it should have everything that you would need, why take the risk of going like an allograft type situation from someone else? But I guess if you could do it autologous, then it may change the story a bit.
Yeah, I mean, I think it's just one of those things is ease. And the marketing, I've seen a lot of like, oh, you don't have to get a blood draw. Really, this stuff's pretty minor. I mean, you look at it and say, oh, we test everything. I go, okay. So my point to my patients are, well, how did the first people get HIV? Blood transfusions. But they tested the entire bank. They just didn't know to test for HIV. Then you fast forward, Zika. Hey, you ever heard about Zika? Well, they tested everything, but people got Zika. Well, they didn't know to test for it. So what is out there that we don't know that we're testing that's clean, but then all of a sudden I get exosomes from someone else, I get sick? Why risk that? I mean, if there's a legitimate medical reason, again, everything is a cost benefit, risk benefit evaluation. I just don't see, and if you look at it, exosomes are most likely an expensive PRP with greater
Mm,
risk. So, I mean, it's a
makes
little
sense.
venipuncture. It's not that big of a deal. Now, for the doctor or the people marketing, I can see like, well, I get this little bottle of exosomes, great. Versus I have to do a blood draw, have someone in my office, process it, make sure they do it right. That, it's hassle. Well, you do it right. Who cares if it's a hassle?
Yeah. No, absolutely makes sense. That was very insightful. Um, awesome. All right. Well, I really appreciate all your time. I feel like we covered a lot of different topics. I think this will be helpful for the listeners maybe interested in this field, those that didn't even know it really existed, because I feel like a lot of people don't even know that regenerative medicine is practiced much in the U.S. And then where can those that are maybe listening to this that could be prospective patients or people that are interested in the fellowship, where can they find you?
Yeah, so I would just look up njregenerativeInstitute.com, or what I've been pushing a lot, we just started. I dragged into the 21st century. I'm not a big social media guy, trying to keep my kids off of it, but we have a YouTube channel. So again, search New Jersey Regenerative Institute. You'll find our YouTube channel. And some of this goes in a little more depth, and we space it across things. We'll keep adding. We try to release weekly videos or so. Again, I appreciate you inviting me in. I hope that, people learn a little something. Again, we sort of skim the surface and put in hopefully a lot of new ideas, thought-provoking things, maybe contrarian things, where people will investigate for themselves and do their own research to find out that, what they're told out there always isn't the whole truth.
Very cool. Well, it was a pleasure having you on. I definitely think I learned a lot from the discussion, and I'm sure the listeners did the same. So I'll link the YouTube and the website below this wherever we end up posting it as well.
Thanks again, and hope to have you come by and you can hang out with us a little bit and see what we do.
Yeah, absolutely. Thanks so much.
All right, have a great night.